Very interesting chakra. So, I'm pretty sure you guys have an idea of what anorexia, bulimia is, binge eating. But let's dive in deep. So before we like talk in depth about what it means, there are so many socio-cultural factors of what our body's supposed to look like, of what beauty is deemed, cultural stereotypes. I'm pretty sure that each culture has a different perspective on what it means to be beautiful when it comes to physical appearance. And eating disorders have everything to do with being occupied with how you look. You are obsessed with food. You are obsessed with how you look, body dysmorphia. I know that with Middle Easterners, although you shove food in your mouth because it means eat, like that's what it means to be healthy. But to be what, thin yet curvy is beautiful, right? I think our modern day society, like the American culture, what's in now, to have that Kim K body. What's the Kim K body? Curvy yet thin yet thick. I don't know what it's called, but that's the standard BBL. Right? um it's like it's this unusual set of rules, right? That we're kind of influenced by them, though. It's so easy to mold a younger generation because that's where it starts, right? That's where it starts. We're influenced by all of it. um and I think like everyone has a certain preoccupation with their own body and how they look, right? Cultural ideal of thinness. I'm pretty sure other cultures feel this way too, right? What do you guys think? People from what would you say? Yesterday's class was telling me that in Asian cultures it's the same. To be thin is to be beautiful in that culture, right? Am I? Any other thoughts on this? Yeah. um, what other cultures? Mexican is very similar with to curves. Yeah, so each culture has their own thing. Identity and self-esteem are dependent on physical appearance. How true is this due to what culture sets, right? Maybe in reality it's not supposed to be like this, but we can all agree that your identity is, well, if you're thin and you look beautiful, then you are, your self-esteem and worth is that much more increased. Lots of colorism, the lighter the skin, the more beautiful. In what culture? In the Latino culture? Interesting. Interesting. Okay. Okay. Wow. I know that then there are other certain cultures who think, the tanner the skin, the more beautiful, right? It's interesting. The cultures that we're from, they set all these different standards, right? So these all come into play. You have a dark baby, light baby. Interesting. Huh. Huh. Shape of the eyes. Interesting. Interesting. Most cultures have all these similar types of factors that are set. We're gonna dive in deep today. It's good. I like it. Female. So there's female attractiveness and male attractiveness, right? Whether we like this or not, it's a dynamic that's been unfortunately set, right? We can all agree on this. So female equated with thinness and physical fitness. If you're thin yet you're fit, you're beautiful, right? That's I'm not saying it's the truth or it's because it's not, right? Beauty comes in all forms and all shapes and sizes, and we can all agree on this. But with that's how it's said, to be attractive as a female, to be thin yet physically fit. The media just romanticizes and glamorizes this idea of being thin. It's always been like, I think we're getting better. I think we're getting better, right? The media is getting better with incorporating all people, real people, right? Real people. We've made a lot of progress. Um, Thinness equated with success and happiness. Um, I've worked with quite a few eating disorder patients, and this is something they always tell me. If I could be really skinny, I could be so happy, and I know that I could get hired for this job. I remember thinking that when I was 17, 18. I remember thinking, I'll tell you a little more as we move forward. Prejudice against overweight. That's true. Dancers are not so thin lately anymore. That's true. That's true. We've made progress in that. early 2000s, it was very true. Model, going to touch on that too. Modeling industry has extreme issues on this. Um, and then I remember I was looking through TikTok, and there was a model who was considered overweight, and she wasn't. That there was all this prejudice against her. She couldn't walk the runway. Did you see that? It was a huge deal, and she was perfect. She was fine. Self-esteem enhanced for those considered attractive. Unfortunate pretty privilege. Pretty privilege. You guys think that exists? Pretty privilege? I think society sets it, right? Unfortunately. Yeah. Pretty privilege. You know, there are two sides to each coin. Pretty privileged, and then they have all these other sets of it's interesting how unreal these standards are. Self-esteem, why would your self-esteem equal how attractive you are? Unfortunately, this is it. This is how it is. Then of course we don't talk about it a lot. Maybe we do, but male attractiveness, ideal body type is lean and muscular. You know, all the Marvel people, all the Marvel guys. That's like the ideal, right? According to culture. Are we in agreement? That's what society deems to be the ideal male attractiveness, right? Chris Evans, Chris Hemsworth, everyone who's casting more emphasis on strength and athleticism, sports, how strong you are. Yeah, less popular if you do not have the ideal body type. Dad bods are more acceptable than mom bods. You know what? That's so true. I saw that on TikTok. TikTok just has it all. I think my source is TikTok. How sad is that? My instructor loves TikTok. Working on my dad bod. But it's the truth. It's how many what's that celebrity that's in Wolf of Wall Street? He had like recently lost a lot of weight, and then now he's talked about more. What's his name? Obviously not Leo. Jonah Hill. Jonah Hill. Um, right. He had like recent weight loss, and he was actually talking about it. How like he's appreciated more now that he looks a certain way, which I mean, I guess in his industry that's the case, unfortunately. But no, with Adele too. With Adele too, yeah. Everyone's talking about her. Yeah. Women feel expected to get mommy makeovers if they don't bounce back postpartum. That's a huge one. Women in postpartum depression. I mean, postpartum period. That's true. I've seen people with Adele. My ex neighbor allowed her son to dress like a girl to help him learn his personality. But now he's muscular. It's an interesting way to teach someone about um, how what they think about themselves. That's interesting. There's no ideal body. It is more about to be a healthy person in good shape majority time. That's true. Yes, absolutely, absolutely, absolutely. I'm about balance. I'm not about extreme measures. It's all about being healthy. I feel good. Not I feel good. What's the right word? I'm okay that Adele started to take care of herself. I'm not glad that Jonah Hill decided to get to that path. What's that other Australian actress? She's really funny. She's in Pitch Perfect. Rebel Wilson. She too had a recent makeover, and she was talking about her health being a main concern as to why she lost weight. See, all of this comes into play. All of it comes into play. Interpersonal factors. So, like, you know, as an adult, this is easy to understand, but as a teen, there's so much pressure. Absolutely. Absolutely. So, factors, risk factors, troubled family, personal relationship, difficulty expressing emotions and feelings, history of being teased, ridiculed, history of physical abuse. So, these are some factors that can lead to eating disorders. Remember, with eating disorders, especially if you receive praise as a child for losing it, exactly. A lot of our cultures do that. Oh wow, look, you lost weight, you look so good. Oh my gosh, you gained weight. A lot of cultures do that. It's true. So with eating disorders, as we talk about it, I want you guys to understand that it's a coping mechanism, right? There's a huge stressor, and we can't control the stress we're going through. But the one thing we can control is food. rigid control of the food that we eat, our obsessive preoccupation with food. Okay, that's what it is. It's a coping mechanism in eating disorder, and these are some factors. Maybe family history, maybe family trauma, trouble in your family, in your relationships, right? Difficulty expressing your emotions. Maybe you're a little introverted and lacks self-esteem. History of being teased. This is me. This is what happened to me. When I was 17, I got teased in high school for being. I got called fat, even though I was not fat. I'm pretty petite, but I was. Certain girls decided to bully me. And there we go. That's where it started. And I'm a perfectionist. If you tell me something and I don't want to say ticks me off. If you tell me something and I take it personally, oh, I'm going to prove you wrong. And of course, at 17, you don't know anything. So instead of dealing with it the right way, I mean, you're still learning to be who, you're still kind of discovering yourself at that age. I decided to starve myself. And then that just spiraled out of control. I'll tell you guys more about it. So that was me. My children are a bit. Actually, my mom cooks good, and we could afford food. I like that. I like that. See, it's different. It's a coping mechanism. Remember, I lacked coping mechanism as a 17-year-old, even though I wasn't. Now looking back, I don't know what was going on with me. Well, now I do. Okay. Um. So biological diathesis stress model. Okay, genetics versus nature versus nurture. I'm the eldest sibling. I have two younger brothers. Yeah. You're referring to me, right? Yeah. I've interesting. Interesting. Yeah. When you have older siblings, it's easier. My brothers have me for that, right? Yeah. It depends on the dynamic you have going on. It's true. See, a support system. Support system. I like that. So, according to theory, relatives of clients with eating disorders are 5 to 10 times more likely to develop an eating disorder. Genetics. Genetics. Okay. So, when it comes to eating disorders, some personality traits, remember, this is a coping mechanism in which you don't eat, in which you starve yourself. Okay. Perfectionism to achieve. It's an obsessive compulsive disorder of food to achieve that perfect ideal body type. Okay, due to social and affective insecurities, because maybe someone ridiculed you, you have an extremely low self-esteem, you don't believe in yourself. Okay, um, oftentimes this starts with young girls, right, or young guys, right? We're talking high school, to immature, sense of ineffectiveness, interpersonal discharge, poor conflict resolution. Someone calls me fat, I don't know how to resolve it. I think, oh hey, starving myself. Okay, which led to depression, which I didn't know at the time, but now looking back, I'm like, whoa, all the depressive signs and symptoms we've learned, I had that. Obsessive compulsive disorder, 1000%. We are obsessed, preoccupied with food. Okay? Now, we're going to dive a little more deep into this. It's all good. So, frequent exposure to, I mean, come on, Instagram, magazines, how many times have I scrolled through Instagram thinking, oh my gosh, this body is so perfect? Do you guys do this? We're all guilty of this. No? Wow, she looks so good. Kind of lowers my self-esteem. Oh, I wish I was a little bit taller, right? Certain occupations are, a little more higher risk. Actors, models, ballet dancers. I know a few ballet dancers, and they're like, by the way, every ballet dancer has an eating disorder. It's just never spoken of. Certain occupations are more, predisposed to it. Athletes and gymnasts generally. So there are certain occupations higher at risk for this. Okay, I don't target this. I don't talk about this, but biochemical. So when you have low levels of serotonin, you eat more. Makes sense. Higher levels, you don't eat. The happier you are, the less you eat. Okay. Um, Norepinephrine increases eating behavior. Suppresses food intake is dopamine. I don't dive into this. Okay. Now, let's do this. Okay. Characteristics. I'm gonna bring myself into it. Even though I'm bringing my example of me, believe me, these are valid examples for Proctored and my exam. Okay. So, extreme self-starvation. It's a coping mechanism in reaction to what is causing us to stress out, whether it's being bullied or problems at home. It's the one thing we have rigid control over. We self starve to achieve extreme perfectionism, which is actually overbalanced. Okay, it's unrealistic, and we reach this um, horrible, horrible outcome in the end. Okay, fear of gaining weight. We are afraid of eating. I am not kidding. I was at one point afraid of drinking water. Okay, um, it comes to that. It's literally a phobia. No, I can't eat a cheese piece that's a little bigger because I'm gonna gain like that extra pound. I can only eat a cube. Okay, these are the way eating disorder people think. Significant weight loss. I initially I weighed what 115, 120, which is good weight for me. Um, and then at my worst, I weighed 83 pounds. 83 pounds. I was a walking corpse. Gnarly, guys, right? 83 pounds. You guys would have been able to count ribs. I was like an anatomy experiment. Fear of gaining weight, significant weight loss, body image disturbance. I would look at myself in the mirror and I would see someone a little more, who had a little more meat on her. But in reality, I was just a standing stick figure. Okay. And we have this idea that if we eat a little more, I remember my mom put a plate of dumplings in front of me. I ate one little dumpling. I couldn't eat two because eating two dumplings meant I was going to gain that like extra pound. So I was still fearful. So after eating that one dumpling, I went for a swim because I'm a swimmer. And I swam that day. I remember this day because I nearly passed out for at least 2.5 hours. And I got out of the pool and I couldn't even remember what was going on. Excessive exercising, excessive where you're about to pass the heck out, and peculiar food handling. Tossing our food away, we're very good at that. You will give us a plate of food and we will cut at it, we will move it around like we're eating, and we're going to be obsessed, and we're going to talk about food because it's the thing that we're really, we're in control of. We won't eat it though. Okay, we won't eat it. And then what's going to happen? My mom would put a food plate. When she wasn't looking, I'd throw it in the trash. How bad is that? Or I would put it back into the pot and I'd be like, yeah, mom, I ate, I'm so full. Or I was really good at lying. By the way, these are all valid signs and symptoms. Okay? Um, Mom, I ate at school. I'm so full. I had like 2 burgers. I can't eat at home. I can't do it, Mom. It's too much for me. Okay? So, lying. Okay, I was really good at manipulating. You know, we would be the ones who's gonna set the table and talk about food, which means that later on they saw me in the kitchen, so that means they're not gonna make me eat. Are you guys understanding this picture that I've painted for you guys about an anorexia? Yes, 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 yes. Okay, good. That's what it is. And remember, coping. This is a coping mechanism. It's the one thing we were able to control. I'm able. You're so welcome. I'm in recovery. 8.5 years. Okay, physical. Everything diminished. Heart rate low, blood pressure low, metabolic rate low, estrogen, testosterone low, body temp low, bone density. I mean, you're about to break low. Menstrual periods gone, gone. Okay, I did not have it for a long time. I messed that up for me. Okay, gone. And that's a real picture that was once what's the word? What did they post photos in the magazine? What did they do? I'm looking for the word. This was in the magazine. Can you believe it? This is a real photo. Yeah. gnarly stuff. Would you guys believe that I had an eating disorder? When I think about it, I'm like, what the? More physical symptoms. Weight loss, 15% below ideal. So yeah, definitely 15% below 83, 82, 83 pounds. And numbers would freak me out. When I would see 1 extra pound, I'd go crazy. Okay, amenorrhea. What does amenorrhea mean? I just said it. What does amenorrhea mean? No period. Yep. Cachexia. What's cachexia, guys? Sorry, guys. Muscle wasting. You're kind of wasting away, right? You're kind of wasting away. Dry skin, completely dry skin because lack of nutrients, right? Sunken eyes, lanugo. Lanugo is peach fuzz all over your body. So as you're wasting away and you're not gaining any nutrients, you develop peach fuzz, little tiny white hairs all over your body, and you develop that when you lack nutrients. Malnourished people get this all over the face, all over the body. Okay, lanugo. Constipation. I mean, you're not eating anything, but even if you sort of start, constipation, cold sensitivity, lack of blood circulation in your body, lack of that cold sensitivity. You're always cold, and weakness. I mean, you're wasting away. You're weak. You're fatigued, right? Your hair's brittle. Your nails break. You orthostatic. I mean, your blood pressure is really low. Like I'd get up, and I'd be like, oh shit, I can't. Like black in front of my eyes. Okay, that is scary. That is scary. That is scary. It was very scary. And by the way, I denied it. I denied. When my mom figured out that something was off with me, she's like, the first thing we actually ask all anorexia eating disorder patients, do you think that you have an issue here with your weight? And I'd be like, nope, I don't. I'm short. This is okay for me. Okay? I don't have a problem. You guys don't understand anything. Right? Denial. We're in denial of the fact that we have a problem. Body image disturbance. This picture is perfect for what I would experience all the time. It's perfect. It's exactly what I remember seeing. Okay? Irrational fear of gaining weight. I'm not kidding. It's a freaking phobia. It's this fear. It's irrational fear that if I sip my water, I'm going to have that extra pound when I get on the scale. Water. Okay? And we're preoccupied with food and cooking. Oh my gosh, I've seen all the cooking channel shows. I would always go by ingredients to bake. When I eat it after I bake, nope. I cut it around, I play with it, and then I toss it. Okay? Very peculiar. Delayed sexual development. Absolutely. I mean, we're so preoccupied with how we look. Okay? Remember, again, I'm saying this, it's a coping mechanism. It's a coping mechanism. By the way, Princess Diana, bulimia and anorexia. Were you guys aware of this? I love Princess Diana. Princess Diana. Yeah. Princess D. Yeah. A bunch of other celeb. Lots of trauma in her case. Yeah, I blame the royal family. But, huh. Yeah. So that was your coping mechanism. Sad stuff. Sad, right? Okay. So hospitalization criteria, greater than 30% over 6 months of weight loss. Remember, heart rate below 40. Systolic blood pressure 70 below. Body temp 36 below. EKG abnormalities, electrolyte imbalances. The moment, so lots of potassium, right? That low on potassium. The moment you start losing all your nutrients and your cardiac system is affected, I mean, good luck. It's tough. Okay, they go hand in hand. Potassium and cardiac go hand in hand. That's what you're watching out for. Now, before we move anorexia care, let's talk about bulimia. Now, this is a cycle, okay? It's episodes, right? You skip meals, right? You have this strict dieting or fasting type periods. You skip your meals, and then you have an episode of binge eating. And I'm not just talking about eating like a whole bag of chips or popcorn by yourself. No, I'm talking about eating everything in front of you. Everything. And then you go and vomit all of it out. Okay? And it's cycles and periods of that. Okay? Again, you're extremely concerned with your body weight and shape. They can be hungry, but not necessarily. I had certain episodes like this too. I was not hungry. It was just a coping mechanism for me. Complete coping mechanism for me. You don't have to be hungry. You just won't know what to do in a stressful situation. And food is the one thing you can control, and you cannot stop. Okay, you cannot stop. Um, yeah, this is it. So you're not necessarily underweight, like anorexia. You can be normal weight, or you can be a little overweight. So you won't really be able to tell if someone has bulimia, if that's the only eating disorder they have. Okay. Fluid electrolyte imbalances, because they're dehydrated, they vomit all of that out. Okay, you're vomiting all of that out. You're losing your electrolyte. There's an imbalance. You have a bunch of arrhythmias. The cardiac system's affected. Okay, your parotid gland is swollen due to the constant vomiting. Okay, you have all these GI problems, gastrointestinal gastric rupture. You can get peptic ulcer, pancreatitis, chronic inflamed sore throat, and this is why. Okay, all of this is happening. Your esophagus goes down. There's a little cap that opens up and down, goes into the stomach, right? When you're eating. Someone with no eating disorder, you eat your food, goes down the esophagus, the little cap goes up, the food goes down, it closes, and then it goes down the intestine and does its, little thing, right? With with bulimia, you're constantly purging, yes? So your body, that little cap, right? That little cap is the sphincter, I think that's what it's called. That little cap, that's H. pylori. That's the sphincter loses its control. Exactly. It stays open, so all your food is constantly going up, and you have a chronic sore throat, right? H. pylori, the acidity, the pH of that, that's what you develop. This is why you have gastric rupture. Okay. Um, Peptic ulcer, food decay. All your food is coming out. All your food is coming out. Your teeth become yellow. You have GERD problems. Absolutely. Absolutely. Um, Russell sign. Your hands are always in your mouth, so you develop calluses along your knuckles. Okay. Interesting stuff, huh? And you're not necessarily underweight. Is that what it's called? Cardiac sphincter? I would just call it sphincter. You guys understand the whole picture of what I'm trying to say? The idea of bulimia? Yeah? Okay, good. That's what I want you guys to. Okay. Labs. Okay. Watch out for all these labs. Hypokalemia, hyponatremia. We all understand why you're losing all of it. Now, you don't just, with someone who has bulimia, you don't just purge through vomiting. That's what you do, right? If you do vomit, if that's your method, your body is in metabolic alkalosis. It's alkaline. Okay. If you use a laxative, it becomes acidic. So metabolic acidosis. Know this. Okay. Obviously, you get your esophageal tears because all that food's coming out. Hypothermia, arrhythmias, intractable vomiting. Intractable vomiting is where you no longer have to purge. Put your finger in a purge. It just happens already. Your gag reflex weakened. Okay. Obviously, guys, at this point, SI risk. Everyone's at SI risk. Okay. Body image disturbance, persistent over-concern with weight, shape, and proportions, mood swings, irritability, self-concept is influenced by weight. Okay? All pertinent signs and symptoms. Now, let's move on to binge. Excuse me. Okay. Can you guys still see my screen? What is going on? Okay, thanks. I don't know. Okay, so then we have compulsive overeating, binge eating disorder. Okay, eating significantly larger than normal amounts in a discrete time period until you're uncomfortably full. The difference here is that you don't purge. There's no vomiting involved. Okay, no vomiting involved. Just eating larger than normal amounts. I think we all have episodes like this. Well, maybe I shouldn't speak for myself. Okay, but there's no vomiting involved. Okay, sporadic fasting, repetitive dieting, and then you just go for it. You eat larger than normal amounts of food. Then you kind of feel guilty when you're stressed out. That's right. But you don't vomit. Okay. Now, with binge eating, there's often high blood pressure, high cholesterol, heart disease, elevated triglycerides, HLP, diabetes, gallbladder from eating all the greasy foods, abdominal cramps and pain. I do this on my cheating the omelet. I should say me too. We all kind of do this. I mean, I do, right? Right. So with binge eating, these are the people that we have that the cardiac history, cardiac issues, right? They're a little on the overweight side. Lots of health problems involved with this. Okay. Lack of With binge eating, there's a lack of self control. You feel shame afterwards, disgusted, right? Like, oh, I can't believe I eat all of this. I feel disgusted. Oftentimes, right, we lots of health issues that we discussed with psych, it's anxiety, depression, and loneliness that go hand in hand. Okay. Now, when you're assessing your clients with eating disorders, make sure you assess their willingness to be treated. Do you have a problem? Do you think you have an issue with this? Okay. Then ask for their history. Okay. Ask if they've lost dramatic amounts of weight or gained them in the past. Get a full history. This is very self explanatory. Ask for their patterns of eating. Okay. Do they have any image distortions, body dysmorphia, physical symptoms, like their vital signs? Are they on the floor? Are they in denial? Right? All of this kind of stuff. I don't focus too much on this. Understand this, but I don't focus on it too much. Okay? Again, our assessment is continued dieting history, binge eating, feelings regarded after binge eating. Do they feel guilty and shameful? Do they have purging behaviors? What's their menstrual cycle like? Any medical side effects? Any other comorbidities? Right? And then lab tests. I mean, everything. Okay? Everything. CBC, electrolytes, calcium, magnesium, right? Well, the potassium goes in the electrolytes, thyroid screening. For bulimia, it's the parotid gland. That's what you're watching out for. Right? FSH, LH, and prolactin for patients who have not had their periods yet. Okay? Know what labs you have to go through. Okay? Obviously, you're doing a continuous EKG if their BMI is less than 18, if there's significant weight loss and there's already hypokalemia and bradycardia, okay, that means you're going to anticipate some cardiac issues. Okay, so you want to do continuous EKG. You're going to watch that heart like a hawk. Okay, if your heart gives up, that's it. Okay, have you guys heard of refeeding syndrome? When you're in recovery, your body doesn't absorb all that food so fast because your heart is having such a hard time processing all those electrolytes and nutrients back. Oftentimes with refeeding syndrome, you can die when you're attempting, and it will literally make you sick. You will just feel like someone is just, I mean, you look like you're dying. You look like you're in hospice. Okay. um, this is what it does. This is lack of everything. when the heart can't take it anymore, this is why you gotta watch that heart like a hawk. And your feeding syndrome should be done extremely slowly. I started when I was so all throughout high school I was just a wreck, and then I started nursing school straight out of high school. The first year I was like, screw this, I don't care. I still had, you know. And then when I hit mental health, I was reading all of this. I was like, holy, like I gotta get my crap together. I started to, get it through my thick head. And plus with West Coast you lose so much energy studying. And then I started developing more coping mechanisms. I was older, I was wiser, sure, whatever. Some other stuff that came into play, and I started to get my crap together. And for a very long time I couldn't absorb anything I was eating. Anything. I couldn't gain weight for the longest of time. I mean, it was misery. And then finally, slowly but surely, I did. Bones. I'm surprised I didn't break any bones, but remember, bone mineral density, like lack of bone density, you're very brittle bones, right? So DEXA scan is for that, okay? Anorexia patients at risk for osteoporosis, osteoarthritis, anything osteo related, okay? We're good on time? Yes, we're. Well, we don't do Nanda anymore. But familiarize yourself with this. You never know how it's going to come up. Know that these are really great nursing diagnoses, okay, for anorexia and bulimia. So I don't focus too much on these next few slides. Your outcomes, okay, your outcomes for all of this, right? To be free of self-harm, okay? Adequate nutrient intake based off of your BMI, right? Manage stressors. You're not just going to medically take care of them. What's that thought? What's going on? Let's involve the therapist. Cognitive behavioral therapy, right? Cognitive behavioral therapy. All that comes into play. All of it. Positive perception of own appearance. Let's try to, move past the body dysmorphia. This is where therapy again comes in. Verbalized understanding of underlying psychological issues. Your therapist comes into play. Okay. Obviously, the goal of nursing interventions with anxious clients with bulimia is to recognize the event, the triggering factor that gives you anxiety, which leads you to your binge pattern and purge pattern. Okay, avoid binge eating and purging in response to anxiety, and vocalize acceptance of your normal body weight, right? Without intense anxiety, because it makes us feel anxious. When I started to gain weight and I started to see that 90 on the scale, I would hyperventilate sometimes. Like it would drive me nuts. And then I thought, nope, we don't think that way anymore. Cognitive behavioral therapy. We don't think that way anymore. We are good the way we are. Look how true mental health is. Unbelievable. Right? Am I the only one who geeks out over mental health? The overall goal of treatment for the individual with anorexia is gradual weight restoration. That is the main goal. Get them back on track with their weight. Target weight is usually chosen by the treatment multidisciplinary team. You got your dietitian, your psychiatrist, your MD, everyone's involved. Okay, so 90% of average. So the goal for discharge is to gain 90% of average weight back. Okay. Establish adequate eating patterns and fluid electrolyte balance. We're going to talk about the main important. Assume a calm, matter of fact attitude as a nurse when you're talking with them, with an eating disorder patient. They're really good at manipulating. So you have to be matter of fact. Like, no, that's not okay. That's not what we do. That's not how we think. No. No is no. Okay? Because they'll get their way. Gradual weight restoration, provide basic nutritional education. That's very self-explanatory. Help increase clients' understanding of treatment plan, emphasize client capability to eat small portions without binging. I'll go over more in depth about this. Avoid power struggle, intervene with anxiety. All the anxiety interventions we discussed yesterday or last week, same thing. Your anorexia patient's anxious, don't leave them the heck alone, right? Give positive feedback when they abide by the plan, engage in group therapy, assist to identify issues, okay, with your identity, with your self-esteem, multidisciplinary team. Okay, that's what this means. I don't dive into this. Okay, this is the one I was looking for. Did I? Oh yeah. Okay. Okay. Weigh patient first thing in the morning using the same scale prior to intake of food. Okay. Every morning, first thing in the morning. I'm sorry. Each morning, first thing. Same scale prior to eating. Same clothes. Check their pockets, because what happens is we like to take heavy objects and we like to put them in our pocket, right? And to make the scale show a larger number, a greater number. Oftentimes, when I was caring for eating disorder patients, I would see like my stapler's gone missing. My heavier object items at work were just gone because we would put them in our pockets. Because they would put, I used to do that too, but we would put it, they would put it in their pockets to check. You ask them, hey, let me check your pocket. Come on. And they know they're not supposed to do that. Stay with the patient during meals and 1 hour after meals. Stay with them while they're eating. With anorexia patients, you want to make sure they don't give it away, and you watch them so they can eat all of it. Because oftentimes they're just going to cut it up, move it around, and they're going to make a mess on their plate, so it's going to look like they're eating, but they're not. Okay. For bulimia, remember, you guys, they like to vomit them. They're going to purge all of it. Stay with them 1 hour after meal. Do not leave them alone at all. At all. Okay. Rewards for amount of calories consumed. So calories consumed, not weight gained. Don't tell them, yeah, you gained 10 pounds. It's going to trigger them like an anxiety attack. Okay. It's wow, you had 500 calories today. Good job. That's what you're rewarding. Calories consumed, not weight gained. Provide high fiber diet, because you guys, constipation. Fiber is what we need. Small, frequent meals. If when we see large amounts of food on the plate, we just go crazy. It's a panic attack for us. Small, frequent, high fiber, small, frequent foods. Okay. Um, Remember, you're staying with their client with anorexia. They like to have a whole lot of exercise. Stay with them restricted. A little is okay. Provide them that autonomy to have a little bit of exercise, but not excessive exercise. So understand that difference. I know it's on the proctor. No caffeine. Restrict. It's a diuretic. It's gonna clean you out. Okay, it's gonna clean you out. Okay, obviously establish trust. That's the first thing you do. Avoid weighing the client daily. So, and then after, as your treatment progresses, you don't do it every day. You do it weekly. First thing in the morning, upon rising, same scale. Okay, away from the scale. Ask the patient to turn away from the scale. This is kind of repetitive. Observe bathroom behavior, record intake and output rigorously, and this is something you delegate to the UAP. That's totally fine. Observe client during meals. That's what we just went over. Stay with the patient during meals. I just went over that. Offer privileges for treatment compliance and weight gain. Yeah. Reward for, what did I say? Calories gained, not weight gained. Calories consumed, not weight gained. Okay. Good stuff, right? This is where it obviously with bulimia, very similar. Maintain fluids and electrolytes, establish trust, health teaching and from education, right? Wait client to evaluate hydration. Same thing applies early in the morning. Observe client when after meals and during, because vomiting. Okay. Medication to manage anxiety. We're gonna talk about meds in the next slide. Excuse me. There is no med that's created for bulimia or anorexia. We treat the behavior. Okay, we treat the behavior. And certain meds, they have an effect on the compulsive behavior. Okay? That's what we're targeting. Okay? So with eating disorders, it's the behavioral and a whole lot of cognitive therapy, cognitive behavioral therapy. We're trying to find why are we thinking this way? Okay? Okay. So there is zinc, olanzapine. Do you guys remember olanzapine? What's the other name for olanzapine? And what kind of drug is that? Isaxaprixa, zinc, olanzapine. We got our SSRIs. So, according to your book, obviously, I just said there are second gen. There are no drugs the FDA has approved. What's going on with me? Okay, research doesn't support any drug for anorexia or bulimia or anything like that. But zinc, we give it for our anorexia patients. It increases the weight gain. It increases weight gain. It opens up your appetite a little bit, and you start to eat a little bit more. That's what the zinc does. Olanzapine, which is Zyprexa, right? It's helpful in improving mood and decreasing obsessive behaviors. Remember, anorexia, we're very obsessive, extremely obsessive. So it's not a lot of the times anorexia patients refuse this med. Now, remember second gen medications? What's one of the main side effects of second gen meds? Zinc was it kind of opens up your appetite. Zinc. That's what it was for. So olanzapine is the second. What's the main metabolic? So what's one of them? What's the main weight gain? The main weight gain. I just don't. This is why they refuse it. They're scared of gaining weight. Okay, this is why they say, "Heck no, I'm not taking this. I took it last time and I gained like 5 pounds." This is why it's not accepted by a lot of our anorexia patients. Okay, they know these meds backwards and forwards. Okay. And then we've got fluoxetine proved useful, but only after the patient reached maintenance weight. So what happens is once our patient reaches like 80 to 90% of their ideal body weight, we can give them this SSRI to manage their mood, and it'll help them to balance their weight. But it's only effective once they reach that appropriate 80 to 90% body weight. Am I making sense, you guys? Makes sense, right? Yeah. There it is. SSRI, reduce. So all these, right, reduces binge eating and vomiting patterns, targets obviously anxiety, depression, obsessions, and impulse control. Okay. So again, they're not necessarily for anorexia or bulimia. Okay. This is all behavioral. That's what we target here. Okay. Imipramine, desipramine, topiramate, naltrexone. So all these drugs, right? Topiramate's good for compulsion. Naltrexone stops the cravings. Um, so these are all what can see, can pee, can spit, can shit drugs. TCAs, hot and dry drugs that we can use. So these antidepressants used to decrease binge purge cycle. Okay, they reduce binge urges. Naltrexone stops. It's off-label use for eating disorder. Again, it stops the craving. So all these drugs that you see right here, obviously, they're all antidepressants given for binge patterns. Okay, for binge eating. Okay, reduces the urge, that non-stop type feeling that you have to continuously eat. That's what happens. It just stops it. It's behavior. That's all this is. Okay. Am I making sense, you guys? Yes. Beautiful. Lovely. And group therapy, big. Big therapy is huge with eating disorders. Like, big time. Big time. Individual, family, group, behavioral, cognitive reframing, cognitive behavioral therapy. I will always mention it because we always utilize it. You've noticed, right, in psych, it's not just in meds, it's meds and always cognitive behavioral therapy. There's just so much you can do by giving your patient a pill. I can give you a pill also, but am I going to talk to you? I can give you my slides, but am I going to talk about my slides? It's the same thing in psych. Like, I can give you the meds, but if I don't talk to you and discover what the heck's going on, then there's no then there's no point in me being a nurse. Gold standard, gold standard, CBT, CBT. Yeah, it is. It really is. It's utilized. It's utilized all the time, and it works. It works with a really good therapist. Oh my! I love doing group therapy with patients. The things I learn. This is kind of saying it again. Occupational therapy, nutritionist is involved here, multidisciplinary team, community support, OA, Overeaters Anonymous, anorexia. There are groups like that. Okay. I remember when I was attempting to get help, I went to Overeaters Anonymous. I sat down and when I was in denial, I was like, no, bye, I'm gone. But it's really helpful. Like talking about it, other people have the same problems. It's all available. It's all available. Obviously, um, screening and education. Nurses can provide screening and education in schools. That's where we start. In schools, right? Clinics, home health, homes, health fairs, health clubs. Okay, individuals at risk, those with low self-esteem, irrational behavior related to food, excessive exercise. So if you have kids, watch out for these behaviors. Sometimes they won't verbalize to you and they'll be very irritable, and then you'll see them constantly exercising and they don't feel good about themselves. Just watch out. Now that you're taking this class, watch out. Watch out. These are good things to consider. Primary, secondary, tertiary care. Oops. Right? Screening and educating. And then if you have it, taking care of it. Right? I don't focus too much on this. Paika. Paika, eating non-food items. There's a show on this. Eating drywall, eating sponge. What else is there? Eating chalk, eating the mattress. What else? What else? What else is on that show? My Strange Addiction. Nail polish, dirt, cotton balls. That's pica. Yeah, cornstarch. I remember I saw someone eating chalk, and she made it look so tasty too. It's a thing. Rumination disorder. Because it was wrapped in like really nice paper. A woman ate her ashes, her husband's ashes. Was this on the show? Oh my gosh. Psych is all around us. Rumination disorder. So, chewing, swallowing, spitting, and doing it all over again. Re-chew, re-swallow, spit out, or vomit out, and do it all over again. That's rumination. Avoid and restrictive food intake. This is where maybe when you're younger and your parents don't let you eat candy and a whole lot of junk, okay, which I think is good. I think it's okay. I think this is more like discipline. I don't see it as a disorder. And then when you get older, you start to eat a little more junk food, or not that you start to eat a little more, but like you can, so you will. You're gonna eat more chips, pizza, like lots of like things you were restricted to eat as a kid. Am I making sense, guys? So that's the comfort foods. Yeah, that's what this is. Although I think it's very valid to not allow your kids to always eat these things. Why? Right? Discipline. It's all about discipline. They don't let me sleep even if I give them chocolate milk. Ah, I see. See, discipline, right? I mean, I grew up in a extremely disciplined household. I think this is why I think that. Yeah. Yeah. Elimination, anuresis, involuntary intentional voiding or urine in clothing or bed. Bedwetting due to a stressor, peeing in bed. Okay? Encopresis, involuntary or intentional inappropriate passing of feces. Or pooping basically out on the hall, in bed. Okay? That's all this is. I don't talk about the subtype. Making sense, guys? Cool stuff to learn, I think. Well, in my opinion. Oh, that's it. Did I go over this? Oh, yeah, I did. Good stuff.